So we can start the session. Now, the very first question goes like this. There is a diabetic male who is having a bloody nasal discharge. There is orbital swelling with pain, and when the culture was done from the pus, it shows broad aseptate hyphae. Which organism can be this? So if we just just write it down, diabetic person with bloody nasal discharge. Okay, there is a nasal discharge which is mixed with blood. Then there is orbital swelling with pain, and when the culture was done, there was broad but aseptate hyphae. Right, so these are broad aseptate hyphae. Now, if you have this kind of picture where there is a diabetic person who is having any involvement of the face in terms of nose or periorbital region, you should make a diagnosis of mucormycosis. Clear? So if you have this kind of presentation, make a diagnosis of mucormycosis, and the causative agent of mucormycosis is Mucor. And Mucor has to be differentiated from aspergillus, and we differentiate it by the way of the hyphae. In Mucor, the hyphae are broad and aseptate, whereas in aspergillus they are small, or you can say narrow, but septate. Clear? So these are the two important differences. One is in terms of size, another is in terms of septations, and there is one more third term, the angle of, you can say, branching. Here it is less than 90 degree, and less than 90 degree in some text you can find the word acute, but here it is 90 degree. Clear? So these are three important differences between aspergillus and Mucor. Clear? So please remember that. And if we look at the image, we can see the difference, obvious difference. The left one is for aspergillus and the right one is for Mucor. In the Mucor, you can see broad hyphae, number one. Then aseptate. You don't find any septations here. So aseptate. And third, look at the angle of branching. It is almost 90 degree. So these are the three features which suggest that the causative organism is Mucor. Whereas, let us see the pattern in case of aspergillus. So here we can see it is quite narrow, okay, something like this. And in the middle we can see the septations. So these lines, these are all septations, right? So we can clearly see the septations here. If I zoom it, you can easily see the septations. These are the septations, right? So these black lines, now these are missing in a slide of Mucor. There are no septations, no black lines, right? Moreover, you can see the size. It is so broad, and see the branching at 90 degree. Whereas in aspergillus, the hyphae are narrow, right? You can see the shape, they are narrow, and we can see the obvious septations in the center, this black line. And also look at the angle of branching, right? So if you look at the angle of branching, this is obviously somewhere around, say, 50 degree. So less than 90 degree, what I mean to say. Clear? So even like here, if we see the septation or the branching, this is also less than 90 degree. So this is how, these are the three important differences between the aspergillus and the mucormycosis. So number one is in terms of the size, broad in mucor, narrow in aspergillus. Second one is in terms of septations, absent in mucor, present in aspergillus. And the third one is the angle of branching, 90 degree in mucor and less than 90 degree, or what you call acute in case of aspergillus. Clear? So please remember this. Then moving forward to the next question, and here a nurse has spilled patient blood sample on the floor. Now how you will disinfect the floor? So blood sample has been spilled on the floor by mistake. Now we have to disinfect the floor. So the best method to disinfect the floor in such a case, yes, anyone would like to answer this? The best way is to use 1% sodium hypochlorite. Clear? So use 1% sodium hypochlorite. Clear? So please remember this. So best agent for disinfection of floor if there is a spilling of blood sample. Then moving forward to next question, what is that mechanism by which the specific information encoded in the nucleic acid chain is transferred to mRNA? So whenever we say nucleic acid chain, you can also say DNA. So the process of transferring of the information from the DNA to the messenger RNA, this is known as transcription. Clear? So this is transcription. And if I say synthesis of proteins from mRNA, if I write it like this, then this is known as translation. Okay, so this is translation. Clear? So transcription, translation. And if there is synthesis of complementary copy from DNA of DNA, then that process is known as replication. Clear? So this is replication. So these are the three terms which you should know in genetics. Replication, that is DNA strand from DNA. Transcription, that is mRNA from DNA. And translation is the synthesis of proteins from mRNA. So this is what is known as the central dogma. So here if you see, this is the central dogma. So from DNA there is formation of mRNA, and this process is known as transcription. And from mRNA there is formation of protein, that is polypeptide chain, and this process is known as translation. Okay, so please remember this. Now next question, a chest physician is performing bronchoscopy in the OPD department, right? Now obviously there are many patients in the OPD, so he have to use the same instrument again and again. So to make the instrument safe for use in the next patient, what is the best way of disinfecting the instrument, right? So here in a OPD setup, the doctor is performing bronchoscopy. Clear? So he is performing bronchoscopy, and yes, it has to be used again and again. So between two patients it has to be disinfected. So what is the best agent to disinfect the instrument before using it on the next patient? Yes, now here the best agent is actually Sidex, like, which is the common term which we use in clinical practice. So Sidex, this is 2% glutaldehyde, and here the instrument should be dipped in for at least 20 minutes for proper disinfection, right? So this is glutaldehyde. Clear? So glutaldehyde. So this is the Sidex solution, which is commonly used in OPD setups, where the doctor has to disinfect the instrument before using it in the next patient, right? So the common term is Sidex, of course. So now this is the picture here, and you can see the instrument, it has been submerged into the Sidex solution, and then it is kept for around 20 to 30 minutes. Let it be disinfected properly, then it will be used in the next patient, right? So any instrument which ends with scope, so it can be bronchoscope, it can be endoscope, it can be cystoscope. So any instrument, right? Very good, yes, except stethoscope. Yeah, agree, right? So any instrument which it can be best, in a best manner, it can be sterilized disinfected by Sidex. Okay, so Sidex solution or glutaldehyde solution. Okay, so next question. Now mother is Rh negative and the fetus is Rh positive. If in the second pregnancy, if there is a hypersensitivity reaction, which type of hypersensitivity reaction it will be? If anti-D was not given after the first pregnancy. So again, this is a case of, yes, Dr. Kanaya, absolutely right. So this is a case of Rh incompatibility. So the mother is Rh negative, the fetus is Rh positive, right? After first pregnancy, usually there is no problem. And what we need to do as a doctor, we have to give anti-D, right? Either there is, you can say, delivery, or there is abortion. In any of the case, we have to give anti-D within 72 hours of the termination of the pregnancy, whether by delivery or by abortion. Now, what happens if this anti-D is not given? If anti-D is not given, right, some fetal RBCs, they will leak into the maternal circulation. So fetal RBCs, they will gain entry into the maternal circulation, right? And the maternal circulation will think them as an foreign body and will develop, or it will form, antibodies. Clear? Now what will happen in second pregnancy? If the situation is same, Rh negative, Rh positive, then what will happen? The maternal antibodies, they will cross the placenta, because these are IgG type, and they will cause hemolytic reaction within the fetus. So hemolytic reaction within the fetus, and what is known as hemolytic disease of the newborn or erythroblastosis fetalis. So this is the actual picture. So here what is happening? The fetal RBCs, they are taken as antigens, and the maternal antibodies are targeting them. So there is hemolysis. So yes, this is a classical example of cytotoxic reaction, which is also known as the antigen antibody reaction, right? So this is antigen antibody reaction. Clear? Or I think if you just give it a number, this is type 2. Okay, so hemolytic disease of newborn or erythroblastosis fetalis. Clear? So erythroblastosis fetalis, or what you call Rh incompatibility, right? So Rh incompatibility. Clear? Moreover, wherever you find antigen antibody reaction, always go for type 2 hypersensitivity reaction. Now, which of the following bacterium shows a safety pin appearance? So the safety pin is something like this. Clear? So somewhat like this. So the bacterium also shows bipolar staining. It means it shows stains at both the ends. So that is bipolar staining. And this is, out of the options, this is classically shown by Yersinia pestis, which is the causative agent for plague. Right? So bipolar staining, safety pin appearance, and this is especially, yes, Dr. Kanaya, Yersinia pestis. Right? So this is classically in the right stain, and here we can see the bipolar staining. Both the ends, they are stained dark, and this looks like the safety pin appearance. Right? So this is the safety pin appearance. Both the ends, they are stained dark, and this is the right stain for Yersinia pestis. Clear? So please remember that. Now, gonococci, it can be differentiated from the meningococci by which sugar fermentation test? So here, if we write gonococci, that is Neisseria gonorrhea, and meningococci, that is Neisseria meningitidis, one way of differentiating the two is by their shape. Right? So yes, Dr. Kanaya, this is maltose. So one way is differentiating by their shape. Now gonococci are kidney shaped, whereas meningococci, they are obviously diplococci with half moon shaped. Okay, so this is kidney or bean shaped, and this is half moon shaped. Now remember, both the bacterium, they ferment glucose. So glucose fermenter, but the sugar, which is, yes, kidney, yes, of course, yes, you are right. So the third is the sugar, and this is only for meningococcus. Right? So this, in terms of sugars, we use maltose. So maltose formation, this is, you can just remember M for maltose and M for meningococci. Right? So if we go here, we can see that Neisseria gonorrhea, you can remember G for G, and for meningitidis, you can remember M as well. So M here, and as Yash rightly said, Neisseria meningitidis also have a capsule. So capsule is also a way of differentiating, and both of these are diplococci, gram-negative diplococci, always seen in pairs. Clear? So this is how we differentiate Neisseria gonorrhoeae, that is gonococcus, and Neisseria meningitidis, that is meningococcus. So maltose for meningococci. Then next question, Mycoplasma is resistant to which antibiotics? So here one should remember one important fact about Mycoplasma, that they lack cell wall. Clear? They don't have a cell wall. Now there are two, very good Dr. Kanaya, very good, beta-lactams. So there are two important points which can be related to this fact. Number one, since they don't have a cell wall, so they can assume any shape. Clear? So they can assume any shape, and therefore we call them pleomorphic. Pleo means multiple. So multiple forms. And yes, as rightly said by Dr. Kanaya, since they don't have a cell wall, so the antibiotics which act by inhibiting cell wall synthesis will be ineffective because their target structure is not there in the bacterium. So these antibiotics, especially the penicillins, they are ineffective because their primary target structure is cell wall. Since Mycoplasma don't have a cell wall, so they enjoy immunity against beta-lactams or penicillin, right? So this is one important thing. And at the same time, you can just add one more fact that they show fried egg colonies. Clear? So you can just add this one more important word, and this is a component of MCQs many a times. Clear? So just remember these few words about Mycoplasma, and here you can see they are looking oval, there they are circular, then some branching pattern. So pleomorphism. So this is to show you pleomorphism. Clear? Of Mycoplasma. The next question, a child has high grade fever and developed sore throat, and when the oral cavity was examined, there was a membrane. Now, which media should be used to culture the organism and to make a final diagnosis? So here the patient is having high grade fever, and yes, the patient is a child. So child with high grade fever, sore throat, and more importantly, membrane in oral cavity. Yes, very good, Dr. Kanaya. Very good, Yash. Absolutely right. Both of you are right. So this is a classical picture of diphtheria. And for diphtheria, please remember two culture medias. One is, of course, Loeffler's serum slope, and the another one is potassium tellurite agar. Clear? In short, you can remember PTA. Clear? So since this is there in the option, so we will mark it as the answer. So the condition is for diphtheria, Loeffler serum slope. Remember, don't confuse LJ media, which is for Mycobacterium tuberculosis, right? So Lowenstein-Jensen media, don't mix up between, because at times students they mix up between Lowenstein-Jensen and Loeffler serum. So both are different and for different bacterium also. Here you can see a classical membrane in the oral cavity. So in a child, if you see this kind of presentation, don't hesitate to think about diphtheria as a diagnosis. Now, a patient with ALL, okay, leukemia, he is having neutropenia. Because of that, he was having fever. Now he developed diarrhea after amoxicillin therapy was started for fever. So a patient with acute lymphoblastic leukemia having neutropenia, that is less neutrophil count, clinically he will develop fever. So the patient was started on antibiotic, and that is amoxicillin here. Now what happened after this amoxicillin? Yes, Kanaya, absolutely right. Now after this amoxicillin therapy, patient developed diarrhea. So this condition is known as pseudo membranous colitis. Clear? pseudomembranous colitis. And pseudomembranous colitis is caused by Clostridium difficile. So whenever there is a antibiotic therapy which has given for a long period of time, patient can develop pseudomembranous colitis, which is caused by Clostridium difficile. Yes, amoxicillin is given here. Another agent can be third generation cephalosporins. Right? So any of the two can cause pseudomembranous colitis, where the patient will present with diarrhea. Next question, a young male presented with bloody diarrhea. It means there is passage of blood along with the stools, and when the stool samples were evaluated, the bacterium was gram negative, oxidase negative, and most importantly non-lactose fermenter, then non-motile and non-H2S producing, so non-hydrogen sulfide producing. So here the bacterium is gram negative, oxidase negative, but more importantly non-lactose fermenter. Clear? Because after this non-lactose fermenter, we will use hydrogen sulfide production to check which organism it is, right? So we will see whether the hydrogen sulfide production is there or not there, right? So especially in non-lactose fermenters, we differentiate the bacterium by the way of hydrogen sulfide production, right? So again I repeat, non-lactose fermenter has to be differentiated on the basis of hydrogen sulfide production. If there is no hydrogen sulfide production, you can go with Shigella, as in this case. So here it is hydrogen sulfide negative, so we will go with Shigella. Suppose if the scenario was this, non-lactose fermenter but hydrogen sulfide production, then you can think of two answers. Either it could be Proteus or it could be Salmonella. Clear? So this is how you should approach non-lactose fermenters which are causing bloody diarrhea. Okay, so the answer in this case will be Shigella, because when we discuss non-lactose fermenters, we have to look for hydrogen sulfide production, right? So we have to look for hydrogen sulfide production. Either it is absent or it is present. So if it is absent, you should think of Shigella, or if it is present, you should think of either Proteus or Salmonella. Now Shigella is non-motile, whereas Proteus and Salmonella, they are motile. Okay, so that's how we should approach this question. Non-lactose fermenter, hydrogen sulfide negative, think of Shigella. Non-lactose fermenter, hydrogen sulfide positive, think of either Proteus or Salmonella. Okay, so this is how we should approach this question. Now a patient has pneumonia and his sputum was sent for culture. The bacterium was gram positive in chains alpha hemolytic on sheep agar. Now which antibiotic should be utilized for making a diagnosis? Now here there are many bacterium which causes pneumonia, but in this case it is given gram positive cocci. Again, when we talk about gram positive cocci, if it is in cluster like a grape, you can think of Staphylococcus, right? So you can think of Staphylococcus here. And if it is in chains, you will think of streptococci. Now this is simply based on their appearance, right? Yes, Dr. Kanaya, absolutely right. Now the streptococci are further differentiated based on the pattern of hemolysis. So pattern of hemolysis on sheep blood agar. So we will check what type of hemolysis they do. So it can be alpha, it can be beta, or it can be gamma. Clear? So it can be alpha, beta, or gamma, and the question is about alpha hemolytic bacterium. So we have to think of alpha hemolytic, where we have two organisms. Either it can be Streptococcus pneumoniae, clear, or it can be Streptococcus viridans. So this is Streptococcus viridans, clear. So to differentiate these two bacterium, we do optokin sensitivity, which is positive here, and this is negative here. So alpha hemolytic do optokin sensitivity. Yes, Dr. Kanaya, absolutely right. So we will go for optokin sensitivity here. And then if the optokin is positive, we will say that the causative organism is Streptococcus pneumoniae, right? So this is here alpha hemolytic, green colonies because of partial hemolysis, and we have to differentiate the two streptococci. One is Streptococcus pneumoniae, which is optokin sensitive, and the another one is Streptococcus viridans, which is optokin resistant. And I think most of you must be knowing that Streptococcus viridans is the causative agent for subacute bacterial endocarditis. Clear? So this is the picture for alpha hemolytic, which shows green color because of partial hemolysis of the sheep RBCs in the blood agar. Anyway, next question. A 5-year-old child is presented with the complaints of cough, running nose, and conjunctivitis, right? So there is cough, running nose, and conjunctivitis. The treating doctor noticed small white lesions inside the oral cavity. Now this is very unique feature, and later on he developed red rashes which started on the face and then covered, then extended up to the trunk. So very good, Dr. Kanaya. The moment you have this kind of presentation, so the child with cough, rhinorrhea, that is running nose, okay. So this is rhinorrhea, that is running nose, and conjunctivitis. Clear? So this is pretty obvious, but what is more important here is in oral cavity there are small white lesions, and these white lesions in the oral cavity are nothing except the Koplik spot. And the moment you have this word, either directly or indirectly in the case history, you have to make a diagnosis of measles, because Koplik spots are very pathognomonic for measles, right? Later on, the child also developed rashes throughout the body. So this is a classical picture of measles, and here this is an image in the oral cavity. We can see the Koplik spots. Clear? So these are all Koplik spots in the oral cavity opposite upper second molar. Clear? So opposite upper second molar. So the moment you have this kind of presentation or this kind of description, don't hesitate to make a diagnosis of measles. Clear? Now a patient has some fungal infection, and when H&E stain was done, hemotoxylin and eosin stain was done, sclerotic bodies were seen having muriform cell appearance. Now which condition is this? So there are sclerotic bodies, muriform cell appearance. Again I repeat, sclerotic bodies which are also known as copper penny or medlar body. Yes, anyone? The moment you have this word copper penny, they look like brown, and muriform means that if suppose this is the cell, they have partitions, right? So this is what is known as muriform. So Dr. Kanaya, yes, this is Chromoblastomycosis. Chromoblastomycosis. And here we can see the classical copper penny. Just look like copper coins, also known as medlar body or sclerotic body. And muriform means they have partition, right? If you see here, they have partition, something like this. So this is what is known as muriform cell appearance. So this is classical for Chromoblastomycosis. Okay, copper penny, medlar body or sclerotic body. Now next question, a gram-negative bacillus can grow in acidic pH. Now which bacterium is this? Yes, Dr. Kanaya, absolutely right. This is Helicobacter pylori, and we know that it resides in stomach. So remember, there are two bacterium which have this capability of residing in acidic pH. One of course is Helicobacter pylori, related to peptic ulcer disease, and the other one is Proteus, which is related to urinary tract infection, right? So two bacteriums, they have this capability to stay in acidic environment, and this is possible by the way of an enzyme that is urease. So this urease converts the acidic environment into alkaline environment, and that is how these bacterium, they are able to survive in such an acidic atmosphere. Clear? So if you see here, there is urease in H. pylori, and this is helpful in neutralizing the acidity, making it alkaline, suitable for the survival of the bacterium. The next question, a truck driver has a past history of painless genital ulcer and now is having rashes which are seen typically over palms. So like truck driver, then painless genital ulcer, right? So painless genital ulcer and now having rashes particularly seen over both the palms. So what is this entity? So I think most of you can, yes, Dr. Kanaya. Now this is painless is primary syphilis and rashes secondary syphilis. Clear? So this is a classical history of syphilis. So in primary stage, there is a single painless genital ulcer with induration. That's why it is known as heart chancre. And later on, the patient will go into the secondary stage where he will have generalized rashes, more importantly in both the palms. So we call it symmetrical lesions, although there will be also involvement of mucosal surfaces like condyloma lata, right? So this is typical secondary syphilis stage where the characteristic lesions are the rashes, and this was the primary stage which has been passed. Now the patient has moved into the secondary syphilis stage. Now next question, a patient has high fever, there is cough, there is confusion and there is diarrhea, and when the chest x-ray were done, it revealed bilateral lung infiltrates. Then the sputum was collected and it showed a faint pleomorphic gram negative rods. Okay, so look at the clinical presentation here. There is fever plus cough suggesting pneumonia. This is one thing, but this is not the end of the question. There is mental confusion and there is also diarrhea. Clear? So there are three things: pneumonia, confusion and diarrhea. They are absolutely right, Dr. Kanaya, you need little correction. No problem. So I'll explain that. Now, pneumonia, confusion and diarrhea. The moment you have these three features, you have to think beyond pneumonia, and that is actually the Legionnaire's disease. Clear? So this is the Legionnaire's disease, and apart from pneumonia, there is also mental confusion, there is GIT involvement in the form of diarrhea, and moreover, what we are seeing here, gram negative. So this is important. Gram negative rods. Clear? Or bacilli. Now this goes more in favor of Legionella pneumophilia. Okay. Now here, why the answer will not be Streptococcus pneumoniae? Because this is gram positive, number one. Then secondly, it is cocci, right? So we can see here Streptococcus. Clear? So this is not the answer here, and please make sure that you get this point. Pneumonia, confusion, diarrhea, Legionnaire's disease, gram negative. Therefore, we have to exclude any organism which is gram positive. As in this case, it is Streptococcus. So we have to exclude Streptococcus, and therefore the answer will come out to be Legionella pneumophilia. Now, next question: which of the following is not true about Ebola virus disease? So which of the following is not true about Ebola virus disease? And before we go into the detail, just let me tell you one thing, that Ebola virus is transmitted with blood. The transmission is through blood or body secretions. Clear? So the transmission is through the blood or body secretions, and we can see here it is human to human transmission is through blood, secretions or other body fluids of infected people, right? So there is no role of mosquito in the transmission of Ebola virus. So Dr. Kanaya, yes, absolutely right. So again I am repeating, there is no role of mosquitoes in the transmission of Ebola virus, and it is transmitted by blood, body secretions or body fluids. The next question: which virus produces Cowdery type A inclusion bodies? So Cowdery type A inclusion bodies. And here you need to remember there are two types of Cowdery inclusion bodies, type A and type B. Type B is seen in cytomegalovirus. Okay, so type B is seen in cytomegalovirus, and yes, Dr. Kanaya, you are absolutely right. Type A is present in herpes simplex virus. Okay, so type A in herpes simplex virus and type B in cytomegalovirus. And let us have a look, how does inclusion bodies they actually look. See, in the normal cell you can see the cytoplasm and you can see the nucleus. So this is the simplest arrangement of a typical cell. But what is being noticed in inclusion bodies, you can see a halo around the nucleus. So there is a white space around the nucleus, and this is what is known as the perinuclear inclusion body. So here also you can see this light space around the nucleus is all the perinuclear inclusion, and that is highly suggestive of the Cowdery type A inclusion bodies. Clear? So seen in herpes simplex virus. Great, Dr. Kania. Now, Pneumocystis jirovecii pneumonia, or what you call Pneumocystis carinii pneumonia, it will be seen if the CD4 count is. So Pneumocystis jirovecii, it is in some text you will also find the word Pneumocystis carinii, that is sometimes we call it Pneumocystis carinii pneumonia, PCP. So that depends. And yes, this is if the CD4 count is less than 200, there is high possibility of a HIV/AIDS patient developing this opportunistic respiratory infection, that is Pneumocystis jirovecii pneumonia, right? So if the value of the CD4 count falls below 200, there is highly likelihood of having this opportunistic infection, which is Pneumocystis jirovecii or Pneumocystis carinii pneumonia. Okay. Now, a patient of HIV is having respiratory distress, and when the chest X-ray was done, it shows bilateral fluffy infiltrates. What can be the causative organism? Yes, yes, Dr. Dia, you are absolutely right, less than 200. So, yes, the moment you have this HIV bilateral, clear, infiltrates. Okay, so bilateral infiltrates. Think of Pneumocystis jirovecii or Pneumocystis carinii pneumonia. So even here we can see there are interstitial infiltrates on the chest X-ray, and this is managed by cotrimoxazole. Clear? So this is managed by cotrimoxazole, and I think most of you must be knowing what are the two drugs here, trimethoprim and sulfamethoxazole, that forms the cotrimoxazole. Chalo, next question. A patient has a history of parvovirus B19 infection and is now having fatigue, tiredness, the hemoglobin is low, and the reticulocyte count is also low. And when the bone marrow examination was done, there was decrease in erythroid precursor. So here what we can see, there is parvovirus B19 infection. Then there in bone marrow there is decrease in erythroid precursor. Clear? So it means the precursor cells, yes, Dr. Kanaya, yes, Chica creation, both of you are absolutely right. So there is a decrease in the precursor cells which forms the RBCs ultimately. So because of low precursor cells, there is low reticulocyte count. Clear? And hence there is low RBC as well, and that is what is written as low hemoglobin. Now just because of this low hemoglobin, there is tiredness or fatigue. So this is how we can see the patient is having anemia, and this anemia is exclusively because of the depression or the suppression of the erythroid precursor, and therefore we will call it pure red cell aplasia. So this is just one form of aplastic anemia where there is suppression of only the RBC series. Clear? So parvovirus B19, please remember it for pure RBC or red blood cell aplasia. There is no synthesis or very less synthesis of the red blood cells. The next question, which has a pencil-shaped macroconidium? Now, which of the following fungus they have a pencil-shaped macroconidium? Now, when we talk about macroconidium, it can be spindle shaped, or what you call board shaped, or it can be pencil shaped, or what you called cigar shaped. So there are two types of macroconidium, and Dia, yes, absolutely right. Dr. Poo14, you are absolutely right. Dr. Kanaya, you are absolutely right. So this is for microsporum, clear? And yes, this is for trichophyton. Yes, absolutely right. All of you are absolutely right. So here we can see the appearance. This is the Microsporum species, which is showing you a spindle shaped or board shaped macroconidium, and here we can see the trichophyton, which is showing a cigar shaped or a pencil shaped macroconidium, right? So just remember this. So macroconidium in Microsporum is spindle or board shaped, whereas macroconidium in trichophyton is cigar shaped or pencil shaped. Then a gardener has multiple vesicles on hand, and then there were multiple eruptions which went through the upper limb along the lymphatics. So this is a classical presentation. I think most of you can, if you just simply look at this kind of presentation, you can simply answer. The vesicles, they are arranged along the lymphatics. The condition is especially seen in Gardner. Yes, Dr. Kanaya, this is Rose Gardner disease, also known as sporotrichosis, and this is caused by Sporothrix shankai. Yes, Dr. Dia, absolutely right. So this is Sporothrix shankai, and this is the classical presentation of sporotrichosis. Clear? So the moment you have any picture which is of course related to gardeners, in which there is a possibility of thorn prick injuries and then eruptions along the lymphatics in upper limb, yes, the answer is sporotrichosis, which is caused by Sporothrix shankai. Now, which of the following is associated with carcinoma of urinary bladder? Because whenever we discuss carcinoma of urinary bladder, we talk about transitional variety, which is because of aniline dyes. But there is one squamous variety which is usually related to one of the parasite, and yes, Dr. Kanaya, yes, Dr. Dia, both of you are right. This is classically schistosoma. So just remember the histology which is associated with schistosoma, this is squamous, and the usual one, which is the commonest one, that is transitional, that is related to other etiologies, especially dye exposure, right? So with this we end today's session. I am very sure you might have enjoyed the session. So next subject will be pharmacology. So till then, keep on studying. God bless. Bye bye.